You walk up to the pharmacy counter, you hand over your insurance card, the tech punches it in, looks at the screen and says, "That'll be $22. You pay it. You leave. You do this every month, and at no point does anyone tell you that the exact same drug, same pill, same dose, same manufacturer is available at that same pharmacy for $6 if you just don't use your insurance. This isn't a glitch. This isn't rare. A landmark study published in the Journal of the American Medical Association found that in nearly 1 out of every 4 prescription claims analyzed, the patient's copay was higher than the actual cost of the drug. 1 in 4 across 9.5 million prescriptions. And for 12 of the 20 most commonly prescribed drugs in America, patients overpaid by more than 33%. The system isn't broken. It's working exactly as designed, just not for you. Today's episode is about 7 words that could change what you pay for medication, possibly forever. What's the cash price without my insurance? To understand why asking this question matters, you need to understand the machine that sits between your doctor's prescription pad and your wallet, because most people think the process is simple. Doctor writes a prescription, pharmacy fills it, insurance covers most of it, you pay a copay. Done. The reality involves a middleman that most Americans have never heard of, even though this middleman touches virtually every prescription filled in the country. They're called pharmacy benefit managers, PBMs, and they are the invisible architects of what you pay for drugs. Here's how it works. Your employer or health insurer doesn't manage your prescription drug benefit directly. They outsource it to a PBM. The PBM negotiates with drug manufacturers for rebates and discounts. The PBM decides which drugs go on your plan's formulary. That's the list of covered medications. The PBM decides which tier each drug lands on, which determines your copay. And the PBM contracts with pharmacies to set reimbursement rates. Now, here's where it gets interesting. Drug companies pay the PBM rebates to get their drugs placed on favorable tiers. A higher rebate to the PBM might mean a lower copay for you, or it might not. The PBM keeps a portion of those rebates. Some of that money gets passed back to the insurer. Very little of it makes its way to the person actually swallowing the pill. The result? Your copay is not based on what the drug costs. Your copay is based on a negotiation between 3 entities: the manufacturer, the PBM, and the insurer, none of whom are required to show you the math. As Lisa Gill, an investigative health reporter at Consumer Reports, put it, the formulary that determines what you pay can be, in her words, very irrational to the consumer. It's not transparent, and you only feel the pain of this price system when you go to fill the prescription. The $285 copay for a $40 drug. Let me give you a real example because this one was reported by PBS NewsHour and it perfectly illustrates the problem. A retired physicist named Ziming Ma was picking up his wife's blood pressure medication, telmisartan, a generic, through their Anthem Medicare plan managed by Express Scripts. The copay for a 90-day supply was $285. Ma thought that seemed high for a generic, but his wife needed the medication, so he paid it. A month later, he needed an early refill before a trip. Insurance wouldn't cover it yet, so he walked into Costco and asked what the drug would cost if he just paid cash. The pharmacist said about $40. $285 through insurance, $40 without it. Same drug, same dose, same pharmacy chain. When researchers at USC studied this phenomenon across 9.5 million claims, they found it wasn't an outlier. Almost 23% of all prescriptions involved a copay that exceeded what the insurer actually paid the pharmacy for the drug. Overpayments were more common on generics. 28% of generic claims involved overpayment, compared to about 6% of brand-name drugs. The average overpayment was $7.69. Doesn't sound like much until you multiply it across hundreds of millions of prescriptions. In their data set alone, total overpayments reached $135 million in a single year. Across the full commercially insured population, the real number is vastly higher. And here's the part that made people genuinely angry. For years, pharmacists in many states literally could not tell you this. Their contracts with PBMs contained what were called gag clauses, provisions that prohibited the pharmacist from volunteering the information that you could pay less by not using your insurance. The pharmacist could see it on their screen. They knew. They just couldn't say anything without risking being fined or dropped from the insurance network entirely. Senator Susan Collins of Maine described the frustration this way. She said the pharmacists she spoke with were beside themselves that they couldn't give that information to customers they knew were struggling to pay a high copay. The law changed, but the habit didn't. In October 2018, two bipartisan bills were signed into federal law: the Know the Lowest Price Act, which applies to Medicare, and the Patient Right to Know Drug Prices Act, which covers commercial insurance plans. Both ban gag clauses. The Senate passed them 98-2. So gag clauses are now illegal at the federal level. Pharmacists can tell you when the cash price is lower. But here's the catch nobody talks about. They still don't have to volunteer it. The law says they can tell you. It doesn't say they must. And most pharmacy workflows are designed around insurance processing. The tech scans your card, the system runs the claim, a copay pops up, you pay it. There's no built-in prompt that says, hey, the cash price is actually cheaper. Which means the burden is still on you. You have to ask what cash price actually means. Let me clarify something, because the term cash price confuses people. It doesn't mean you literally pay with physical cash. It means you're paying for the medication without running it through your insurance. You can use a debit card, a credit card, even your HSA card. You're just telling the pharmacy, don't bill my insurance. What's the price if I pay out of pocket? The cash price includes three components: the pharmacy's acquisition cost, what they paid the wholesaler for the drug, a dispensing fee, and whatever markup the pharmacy adds. That markup varies from pharmacy to pharmacy, which is why cash prices differ between CVS, Walgreens, Costco, and your local independent. The national average copay for a generic medication is about $6.61, but many generics have an actual acquisition cost to the pharmacy of literally pennies per pill. When the system tacks on a $10 or $15 or $20 copay for a drug that costs the pharmacy $2 to acquire, the difference isn't going to you, it's going to the PBM. Now, the cash price at the pharmacy counter is one option, but an entire ecosystem of discount tools has emerged that can push prices even lower. GoodRx is the most widely known. Founded in 2011, it aggregates negotiated rates across multiple PBMs and displays them by pharmacy. You search your medication, see prices at nearby pharmacies, and either print a coupon or show a code on your phone. GoodRx tracks prices at more than 75,000 pharmacies nationwide. It's free to use. Then there's Mark Cuban's Cost Plus drug company, launched in 2022. Cost Plus takes a completely different approach. It bypasses PBMs entirely. It buys generic drugs directly from manufacturers, adds a flat 15% markup and a $5 pharmacy fee, and ships to your door. That's it. Every drug, same formula. No hidden negotiations, no rebate games. Studies have found that Cost Plus's average medication cost is about $17 per prescription, compared to roughly $31 through GoodRx. Cost Plus currently offers over 1,000 generics. Amazon Pharmacy offers its own discount program through Prime. RxPass gives members access to eligible medications for $5 a month total, regardless of how many prescriptions. SingleCare is another major discount platform, and Costco, Walmart, and several other large retailers offer their own low-cost generic lists, some as low as $4 for a 30-day supply. A critical thing to understand: when you use any of these discount programs, you are paying a cash price. You are not using your insurance, which brings us to the most important nuance in this entire conversation. This is where I have to pump the brakes on the always pay cash narrative, because there's a scenario where paying the lower cash price actually costs you more in the long run. If you have a high deductible health plan, and roughly 84% of large employers now offer one, your insurance doesn't start covering prescriptions until you've hit your deductible, which might be $2,000, $3,000, even $5,000. During that deductible phase, you're paying the full negotiated insurance price for your meds, which might be higher than the cash price. So the temptation is to skip insurance and pay cash. And for that individual transaction, you'd save money. But here's the catch: payments made through insurance count toward your deductible and your annual out-of-pocket maximum. Cash payments and discount card payments do not. This matters enormously if you're someone who typically hits your out-of-pocket max. Maybe you have a chronic condition. Maybe you have expensive medications later in the year. Maybe you or a family member has a planned surgery or hospitalization. Every dollar you route through insurance gets you closer to that ceiling. Every dollar you pay cash stays invisible to your insurance math. So the right question isn't just, is the cash price lower? It's, am I likely to hit my deductible or out-of-pocket max this year? If the answer is yes, routing prescriptions through insurance, even at a higher per transaction cost, may save you more money overall. If the answer is no, you're generally healthy, you're on one or two cheap generics, you're nowhere near your deductible. The cash price is almost certainly the smarter play. One exception worth knowing: Medicare. Part D has a specific rule that if you pay a lower cash price for a covered drug at a participating pharmacy and submit the proper documentation, your plan must count it toward your out-of-pocket expenses. Most commercial plans do not have this provision. The human cost, 98 million abandoned prescriptions. Here's why this matters beyond personal savings. 98 million new therapy prescriptions were abandoned in the United States in 2023. 98 million. A 2023 KFF survey found that 21% of adults reported not filling a prescription because of cost. Another 31% said they weren't taking their medications as prescribed because they couldn't afford to. Cutting pills in half, skipping doses, stretching refills. Nearly 1 in 4 Americans taking prescription drugs says it's difficult to afford them. Medication non-adherence is estimated to cause 1 in 10 hospitalizations, approximately 125,000 preventable deaths annually, and costs the U.S. healthcare system up to $528 billion a year. People are dying, not because the medication doesn't exist, not because the doctor didn't prescribe it, but because the price at the counter was too high and nobody told them there was a cheaper way to get the exact same pill. And half the time, a simple question would have changed the outcome. So here's the practical takeaway. This is your protocol for every prescription, every time, at every pharmacy. Step 1. When you drop off the prescription, say these 7 words. What's the cash price without my insurance? Just ask. The pharmacist can and will tell you since 2018, federal law explicitly allows it. Step 2. Before you go to the pharmacy, check GoodRx, Cost Plus, Single Care, or Amazon Pharmacy for your specific drug and dose. This takes 30 seconds on your phone. Now you have 3 price points: the insurance copay, the pharmacy's cash price, and the best discount program price. Step 3. Consider your deductible math. Are you likely to hit your out-of-pocket max this year? If yes, lean toward insurance even if the per-transaction price is higher. If no, take the lowest price from your 3 options. Step 4. If you're on a brand name drug, ask your doctor about generic alternatives. The average copay for brand name drugs is nearly $56. For generics, it's about $7. And for the vast majority of drugs, the generic contains the same active ingredient and is therapeutically equivalent. Step 5. Consider buying in bulk. A 90-day supply is almost always cheaper per pill than 3 consecutive 30-day fills. Many insurers encourage this, and discount programs like Cost Plus and mail-order pharmacies build it into their pricing. Step 6. If you're on Medicare Part D, know your rights. You can pay the cash price and submit documentation to have it counted toward your out-of-pocket spending. This is a little-known provision that the government itself doesn't actively publicize quite so. I want to close with something a pharmacist named Nick Newman from a pharmacy in rural Ohio told NPR. He said, "If they bring it up, then we can inform them of those prices." That's the whole game. If you bring it up, the information is there. The pharmacist has it on their screen. The law now protects their right to share it. But the system is designed around the assumption that you won't ask. Every workflow, every screen, every process defaults to running your insurance card and presenting you with the copay. The cash price sits 1 question away, and most people never ask the question. The average American fills roughly 12 prescriptions per year. If even a few of those have a cash price that's lower than the copay, and the JAMA data suggests 1 in 4 will, the savings add up to real money, not theoretical money, not money in a spreadsheet. Money you keep in your pocket because you asked 1 question at the counter. 7 words. What's the cash price without my insurance? Ask every time.